Good morning. Today I'll be talking about gallbladder dyskinesia and the role of nuclear medicine in the same. So just coming to chronic cholecystitis, there are two types of cholecystitis, mainly calculus and an ill calculus form. So 90% of this chronic cholecystitis is usually this calculus form, and about 10% is this ill calculus form. So the common presentation of a chronic cholecystitis, when you usually talk about, is the calculus form, and these patients present the classic history, which is usually a middle-aged woman who presents with a right upper quadrant pain, and it is occasionally seen in men and children as well. So they then do an ultrasonography which detects the gallstones, and that is a confirmatory investigation. And it goes on go on to do a cholecystectomy, and the HPE proves the chronic inflammation which is seen in the HPE. So in case the clinician feels the gallstones are just incidental in this case, he can then refer the patient for a cholecystography and to look at the gallbladder ejection fraction. So this in this cases, the cholecystography classically shows a delayed filling after 60 minutes, and some cases can show a normal filling as well. So here, when cholecystokinin is administered, uh, asymptomatic if it was asymptomatic cholelithiasis, they usually have a normal gallbladder contraction, while if the cause was the stones itself, they would have a poor gallbladder response. So I'll come to what is cholecystokinin action and all that for the slides. So coming to the topic, today's topic is basically on the acalculous form. So that is a chronic acalculous gallbladder disease. So as I said, this is seen in approximately 10 patients of the 10% of the symptomatic chronic gallbladder disease. So it is clinically and histopathologically indistinguishable from the calculus form, except that there are no gallstones. So this condition is also known as the gallbladder dyskinesia or gallbladder spasm, or cystic duct syndrome, or functional gallbladder disease. So how does a patient with dyskinesia present? So gallbladder dyskinesia would present the same like a chronic cholecystitis. So patients present with a recurrent biliary type pain. That is the main presentation, and it is usually present in the epigastrial region or the right upper quadrant. This can be associated with nausea, vomiting, radiation to the back, and that infrasubscapular region. And also, it should be a severe pain. So the underlying mechanism of why biliary why this happens is not certain, and the treatment for the same is just cholecystectomy. That is was the same as for both the chronic cholecystitis, and this is basically done just for the pain relief. And pain relief also has been seen to be only from 66 to 100% in this variety. So coming to how do you diagnose biliary dyskinesia? So there is a Rome 4 criteria. So this Rome 4 criteria has a diagnostic criteria and a supportive criteria. So under the diagnostic criteria, there are two criteria among which both should be included. So the patient should have a biliary pain, and the structural imaging should show the absence of gallstones or a absence of structural pathology. So they also go ahead to give the criteria for a biliary pain. Biliary pain should is a pain that is in the epicrystum of the RUQ, which lasts for about 30 minutes or longer and occurs. It should not be a daily pain. It should occur at different intervals, and it should be severe enough to interrupt daily activities. So this should not be related to the bowel movements, and I mean the pain should not decrease with bowel movements, and it should not also um, change with the position of the patient. And the supportive criteria for this is a low ejection fraction on the gallbladder scintigraphy and normal liver enzymes or conjugated bilirubin amylase lipase and all that. So this supportive criteria is where nuclear medicine comes to play, where we show the low ejection fraction on the gallbladder scintigraphy. So what is it? It's basically a synclide cholecystography that is used to confirm a clinical diagnosis of a chronic acalculous gallbladder disease. So why is it done? Basically, a normal GBF rules of the disease, while a poor GBF, that is the gallbladder ejection fraction, predicts how the post cholecystectomy, how the patient will be. So if it has a poor GBF, that means the patient is more likely to get symptomatic relief from a cholecystectomy. And studies have shown to have a positive predictive value of over 90%. So what are the radiopharmaceutical used in this study? So it's basically the same. So that is used in HIDA study. So that's basically derivatives of the immunodigestic acid. So there are two more common agents, that is disophenin and mebrofenin. So the trade names are hepatolite and polytech. So they are both binded with bounded technetium. So the physical half-life is 6 hours. So what is the mechanism of uptake? Both the agents have a similar mechanism of uptake. So basically, once given intravenously, they are tightly bound to proteins, mainly albumin, and hence there's a minimal renal clearance. So via organic anion exchange, it is extracted and excreted by the liver. So it's taken up by the hepatocytes by this organic anion exchange, and then it is again excreted by the liver into as say similar to bilirubin. And unlike bilirubin, it does not undergo any conjugation or metabolism. So then this radiotracer then enters the gallbladder via the cystic duct and goes on to enter the duodenum via the common bile duct. So the distribution of this tracer basically it depends on the patency of the ducts, the sphincter of Oddi tone, and the intraluminal pressures. And a gallbladder should be normally visible before the bowel activity is visible. So this is the flow again seen. So it enters the liver via the portal vein, and then it enters the canaliculate taken up by the hepatocytes via the anion exchange, and then it is secreted into the bile, and it goes on via the cystic duct into the gallbladder and via the common bile duct into the GIT, into the duodenum. So normally the gallbladder is supposed to be, supposed to start filling by about 10 minutes, and it's usually seen in 30 to 40 minutes. And we give a time, and in these cases, it can take up to 60 minutes. But after 60 minutes, it's considered delayed visualization. So the activity that is used for both the same for both the traces, and it's usually 3 to 5 millicurie. And for a pediatric patient, it's usually 0.05 millicurie per kg. So, and you need a minimum recommended activity of 20 MBQ, that is 0.5 millicurie at least. So it is also seen that they have a competitive inhibition with an elevated serum bilirubin because they have the same pathway of uptake. So as your serum bilirubin is elevated, you will have to keep increasing the dose of the activity that you inject as well. So what is the patient preparation required before the study? We basically have to take a good history where the last meal that was taken, if there was any opioid administration, that's a major drug we look for. And then if there is any prior gastrointestinal surgeries done, and then we look at the bilirubin levels, and we also look at the structural imaging if anything was done. So we usually recommend EANM usually recommends a NPO for about 4 hours. 4 to 24 hours is okay, but about 24 hours they don't recommend. And for patients taking opioids, they also say that you should give a gap at least of 4 half-lives of the opiate medication. If it's not known, then you at least give a 6-hour interval from the last opioid. So these are the all the drugs that are generally cause inhibition of the gallbladder contraction. So the common ones include opiates. That is basically this opiates. What happens is it will constrict the sphincter of Oddi and hence delaying the emptying into the GIT. Atropine again antimuscarinic, so it will cause smooth muscle relaxation and all that. And again, nifedipine, calcium channel blocker, again it will cause smooth muscle relaxation, all decreasing the gallbladder contractility. Even progesterone has the same effect. OCPs has the same effect. Alcohol also decreases. All these are common things we can look for in the history, and all decrease gallbladder contraction. So what are the diseases or conditions associated with poor gallbladder contraction? The most common that we see in the clinics would be diabetes, obesity, cirrhosis, pregnancy, and the other less common ones are also mentioned here. So how does cholecystine act? What is cholecystine? Cholecystine is just a polypeptide hormone which is released by the proximal small bowel. So it is basically released for the digestion of fat and protein. So in response to the ingested fat and the protein, the small bowel releases the NSAID. So it is the terminal part of this hormone that is actually the active portion of the hormone. And what does it does? It causes the contraction of the gallbladder and the relaxation of the sphincter of Oddi. So this causes the discharge of bile into the small intestine for fat absorption. So this is the structure of CCK. So if you come to the last, this terminal part is what is the metabolically active part. So Synclide is nothing but the analog of the terminal octapeptide of the CCK, and that is what is commercially available. So when we do the study, we give Synclide to mimic the activity of cholecystokinin. So what are the indications? We are going to use it for diagnosing this acalculous gallbladder disease. That is our gallbladder dyskinesia, but it can also be used in the other conditions as mentioned. Before a HIDA study, if you want to give, it's usually given when the period of fasting is more than 24 hours, or to diagnose a sphincter of Oddi dysfunction. Or you can give it after the initial HIDA examination if you wanted to differentiate a common duct obstruction from a functional cause, and so on. But what we are going to do is for basically for diagnosing this gallbladder dyskinesia. So this is what ENM suggests. So first you'd look at the duration of fasting. If it's less than 4 hours, you wait for 4 hours and then proceed. If it's 4 to 24 hours, which is the ideal what they recommend, we proceed by injecting the radiopharmaceutical. If it is more than 24-hour period of fasting, we would inject Synclide and wait for about 20 minutes and then inject the radiopharmaceutical. Now, after injecting the radiopharmaceutical, in whatever case, we would image for 60 minutes. And after 60 minutes, we would see if the gallbladder is visible or not. If the gallbladder is visible, then we inject the Synclide, or the alternative is giving a fatty meal. And then we image for up to 30 to 60 minutes. And in that images, we calculate the gallbladder ejection fraction. If the gallbladder is not seen, then you have to inject morphine to visualize the gallbladder. And after injecting morphine, you can't actually do the study. So gallbladder ejection fraction, how do you calculate it? Basically, as I told, you wait for the first 60 minutes and visualize the gallbladder. And after that, you would inject Synclinide. So the dosage at which you inject is 0.02 microgram per kilogram. And it's administered intravenously over 30 to 60 minutes. So this alternative to Synclinide is the fatty meal that we give in CMC. But ENM now Resinamide has a standard guideline for what type of meal, dosage, or amount of meal. But they mentioned that fatty meal can be, you can give whole milk or ensure as a substitute as a fatty meal to the patient. So how do you calculate the GBF? You would take the maximum counts, that is just after injecting the Synclinide, and the minimum counts, and subtract the both. Minimum counts would be the at the end of the Synclinide infusion. What counts you get from the GB, it would be the minimum counts. You subtract both of them and divide them by the maximum counts into 100 would give you a gallbladder ejection fraction percentage. So just a review of the procedure. First, you'd ensure the gallbladder is filled. Then you position the camera in the left anterior oblique projection. So that is basically, they say that it can differentiate if you have a confusion between gallbladder activity and the rest of the biliary system. They prefer you to do it in a left anterior oblique projection. And then you would give the Synclinide infusion at the dose of 0.02 microgram per kg over 30 to 60 minutes. And then you begin imaging at the start of the infusion and end the imaging at the end of the infusion. And then you get your counts, the starting counts minus the end counts by the starting counts would give you the ejection fraction. And you'd also get the time activity curve accordingly. So this is what the interpretation of GBF is. They have come to a consensus that when you're giving a 60-minute infusion, if it is less than 38 percentage, that is then it is called as abnormal gallbladder ejection fraction. So coming to the textbook normal, so these are all images taken off from Thrall. So they draw the ROA around the gallbladder at 1 hour whenever the gallbladder is visualized, and then they start the infusion. continued for about 1 hour, and then they calculate the ROI, and here the ejection fraction was seen to be 59%, which is normal. And this is diagnosis of gallbladder dyskinesia was made because minus when the final counts were subtracted from the initial counts, they have got a percentage of only 21. While we know that less than 38 is suggestive of dyskinesia. So this was one of our patients. But this is actually a 7-year-old boy who presented with abdominal pain for 2 years, but ultrasound showed cholelithiasis. So they wanted to know if it is symptomatic or asymptomatic cholelithiasis. So here are so when we do a fatty meal instead of the synclinal infusion, so we've taken the ROI at this point of time, and then we take an ROI at half an hour, 1 hour, and 2 hours after the meal is given. And we have found ejection fraction of 44 and 61 basically at 1 hour after the fatty meal. It was 61 at 1 hour after fatty meal, so it was normal. And then the doctors also kept the patient on follow-up. So coming to summary, chronic acalculous gallbladder disease is what is called as gallbladder dyskinesia, and it presents as a biliary type pain in the epigastrium or right upper quadrant, or usually associated with nausea, vomiting, radiates to the back, and usually wakes the patient from sleep. According to the Rome 4 criteria, you should have an epigastric or RUQ pain that builds steadily, lasts for more than 30 minutes, is intermittent but not daily, interrupts daily activities, and no gallstones or structural pathology should be found on structural imaging. And the supportive criteria include the low GBF on scintigraphy and a normal labs. So your diagnosis would be aided by the synclinide polyscintigraphy, where a poor GBF predicts the post-cholecystokinin relief that is seen in about 66 to 100% of the patients, and a normal GBF excludes the disease. So the pharmaceuticals used are disophenin and mebrofenin. The activity commonly given is 3 to 5 millicurie, that is 111 to 185 mbq, and is given as IV. And we usually, for the we take a history of the drugs, we take a history of surgery and all, and NPO preferred is 4 hours. We avoid NPO of more than 24 hours, and interval from the opioid at least 6 hours is given. And the gallbladder fills by about 10 to 40 minutes. So at about 60 minutes, we start the infusion of synclinide at the given dose, that is 0.02 microgram per kg IV infusion over 60 minutes. And this causes the gallbladder contraction and sphincter of Oddi relaxation. And we calculate the counts by taking a maximum minus minimum by the maximum counts into 100, giving you the percentage. And normal is usually about normal is about 38%. If it's below that, it's called gallbladder dyskinesia. These are references and